All right. So Rob had a good question. And just talking more broadly of all modalities, we're going to have these times when we're going to have to really think like, should I apply this modality or not? Number one benefit for most of the modalities we're going to cover, at least 85% of them. What's the number one effect of any of the modalities we're going to be talking about? Non-painful stimulus, feels good. That's the number one thing. Physiologically, when we start talking about our superficial heats, we're also going to start talking about superficial colds. Physiologically, let's stick with heat because we know more about it. Penetration depth is what? So physiologically, are we getting all of the benefits, the theoretical benefits from a hot pack that we should be? What are some of the benefits of a hot pack, broadly speaking? Increase blood flow, increase elasticity of the muscle, put it on stretch, reduce the muscle spasm, right? There's a lot of things it can do. Physiologically, though, would you say that we're definitely getting those benefits or we might be getting those benefits? Might be, right? So I think it's really important to be skeptical on, okay, what are we actually doing here? So if I am looking at a patient and if they do have some precautions, I think there's a lot of other ways I can introduce non-painful stimulus that maybe they don't have the same precautions for. It might be safer for my patient. And because I'm so skeptical on what is this modality actually doing to the target tissue that I want, if it's superficial, wrist muscle tendonitis, all right, well, that's really superficial. I think we can actually use a hot pack for this. That's really exciting. Glute strain, low back strain. What do you guys think? Are we actually getting to that target tissue? Probably not. So it's really important to be skeptical on what is the modality actually doing. It gives us an opportunity to choose maybe a different modality that's going to be more safer for that person, but we're still going to get the non-painful stimulus out of most of the modalities we talk about. So that's really good. So we have options for us. And that's always going to be part of our clinical judgment. And that's, again, why we get paid is because we get to struggle with hot pack versus fluidotherapy versus massage versus something else. Like that's why we get paid what we do. All right, so we're going to move towards other thermotherapy. Cold packs are next, or just cold in general, I should say. So contraindications: lack of intact sensation, vascular insufficiency, recent hemorrhage, malignancy, acute inflammation, infection, over limit or heat rubs, or any situation deemed unreliable by the PT or PTA. So cryotherapy, generally used for the first 24 to 48 hours after an injury. It can affect the temperature of the tissue at depths 1 to 4 centimeters. So our penetration depth can be a little bit deeper. So that's nice. And the big thing we want to educate our patient on is the stages of perceived sensation, C-band. First, it's going to feel cold, then it's going to be burning, then it's going to be aching, and then we're going to reach numbness. Now, we do want to reach numbness. That's really important for our patient, because when are they going to want to stop at? Or cold, or or ache. There's a lot of discomfort to get to that actual therapeutic numbness portion. So that's going to be really important for us to have that good patient education for. So the goals for cryotherapy, well, decreased pain, non-painful stimulus, that's great. Cold also slows nerve conduction velocity a little bit better than heat does. So it's going to have a more prolonged effect for pain relief than what a hot pack or superficial heat would. Decrease inflammation, decrease edema, decrease muscle spasm and guarding, and decrease muscle spasticity. So it's going to slow nerve conduction velocity a little bit better. So that'll have a greater, longer lasting effect of pain relief. Basically, if you're if you're going to choose modality to go to bed, you're going to go to bed in 20 minutes. What do you want to do for pain relief for overnight, hot versus cold? Well, cold is going to have a longer duration for it. So cooling tissues greater than 10, less than 10 degrees Celsius may result in tissue damage. So again, we still want to protect our patients. Do not want to give them frostbite. That wouldn't be a great day for us. A lot of paperwork to fill out, and I don't like to do extra paperwork. The depth is between 1 and 4 centimeters, around 8 minutes duration, 1 to 2 centimeters deep, 20 to 30 minutes. We're going to achieve depths of 3 to 4 centimeters. So it's going to take a little time to get to the deeper tissues. We have mild intensity or more intense intensity. Mild intensity, you're going to have a dry medium in between the cold and the patient's skin. That's where the towels that we were using before last week, that's the dry medium. If the towel was wet, or when we do ice massage, that's now a wet medium. That's going to be more intense. So the treatment time does depend on the tissue depth that we want. If it's more superficial, we can go shorter duration, or roughly 8 minutes will be fine. If it's deeper, we'd want more longer. We want to prevent vasodilation. So that's called the Lewis-Hunting response. So what that is, and I'm sure we've probably all seen this maybe on really cold days. I guess on Saturday it's supposed to be really cold, right? So maybe on Saturday we'll all wear minimal clothing and go run around outside and see if we can see this. What the skin looks like, it looks like that just splotchy pink and white appearance for it, that ultra cold. So that's actually creating vasodilation now. So again, like if we think back to the body's response to cold is actually to increase blood flow to the area. So if we want to prevent that, we'd want to stop before we get that reaction. So that can be a tricky thing for us. Intense cold for short duration, 10-ish minutes, is good for acute pain and inflammation. Longer duration, we might want to create that Lewis-Hunting response. So we would want longer if we wanted that. Less intense and longer duration, 20 to 30 minutes, good for edema, good for muscle spasticity. We don't really care about preventing vasodilation for that person. Some indications for pain. Again, we're using non-painful stimulus we're using the gate theory to block pain. We can reduce muscle spasm with this, decrease metabolic rate, decrease acute inflammation response. If we're going to do this, elevation and compression is also going to help. We want about 1 hour in between cycles of icing, just so we don't create that overcooling effect. Either we want to prevent that Lewis-Hunting response, that vasodilation reflex, and also we want to protect the integrity of the skin. We don't want to create a frostbite situation. Reduce muscle spasm, we want to do the longer duration, 20 to 30 minutes, depending on the depth of the tissue. We can also reduce edema with it. Contraindications, any thermal regulatory problems. So Raynaud's disease, Wheels reaction, where we get that hypersensitivity to cold. Wound healing in the initial first 2 to 3 weeks. Cryoglobulinemia, that's a fun one. Rare disorder where blood coagulates in response to cold. So yeah, you're gonna have a lot less pain, but we're gonna give you blood clots. So not a great balance. And over regenerating peripheral nerves, we don't want to touch those. Let them go. Here's a picture of Raynaud's. Here's the Wheels reaction. Oh. Oh, yep.
Is that more on the intense, like extreme side of it?
Yeah. Usually, in my angle, you can't quite see this on this screen, but usually just the really white fingertips is what you would see. That's that dark color. I haven't seen. I have seen the white response, but.
What happens with Raynaud's? They're very sensitive to the cold or skin breaks down?
Hypersensitivity to cold, the reaction is the distal fingertips turn white, usually painful as well. And then once the blood flow returns, it becomes it's painful as it returns as well. Yep. Raynaud's, does Raynaud's prevent vasodilation? Is that? Yeah. Well, it cuts off blood supply initially. So that's why it turns white like that. Some precautions, sensory deficits. Again, if the patient can't feel it, we're at risk for injury. Impaired circulation, high blood pressure is a unique one. So cold application causes a transient increase in blood pressure. That's temporary increase in blood pressure. Cold over a deep wound, aversion to cold. Not everybody likes it. And then again, over superficial peripheral nerves, the peroneal nerve. So this is intact nerves. So the contraindication is over regenerating nerves. This is intact nerves, but the more superficial ones like the peroneal nerve at the fibular head, we want to stay away from. So a couple of methods for it. First up, we practiced last week, cold packs. Cold packs stored in freezer units, contain semi-gel substance, stays cold for about 10 minutes. Need to let it cool back down for roughly 30 minutes in between uses. Busy clinics. How many people work in busy clinics where that actually happens? Doesn't, right? Does it happen in yours? No. So again, like I'm hypercritical on all modalities. Effectiveness of cold pack, just basically on thinking along the lines of treatment duration, also depth of penetration. How do you think we're actually doing, like physiologically, not psychology of the non-painful stimulus, but physiologically? Do you think we're doing a lot to the target tissue? Probably not a lot, but then also if we introduce user error where the cold packs aren't being sufficiently cold in between uses, now we're even reducing our physiological effectiveness anyway. So I'm hypercritical on that. If we're going to use it directly on the skin, we want some sort of barrier in between, wet or a dry towel or pillowcase. I don't see wet used very often. It's usually it's dry. Again, why would we want to use the wet towel or pillowcase? Yeah, to increase the intensity of the cold transfer. That might be what we want. Patient comfort, what do you think? So if the number one thing we're doing is non-painful stimulus, what do you think? All right, a little skeptical on that. How about if today, if I said, okay, guys, grab a bunch of pillowcases, get them nice and wet, and then put them on yourselves, how would you feel the rest of the day? Yeah, I mean, one, it's going to be a mess. Two, you're going to be wet the rest of the day, right? There's some sort of article of clothing that's going to be wet for you for the rest of the day. So now patient comfort later in the day, what do you think? Are they going to think back to they have to go to their office job and their shirt soaking wet, and they're going to think like, I had a good PT session today. Like, no, they're going to be thinking of you all day long, but not because they are thinking happy thoughts. One big thing with cold packs, what's the type of heat transfer using for both hot packs and cold packs? Conduction heat. So we need contact, right? So that's where our straps are really, really important for cold packs. They don't stay in place as well. Definitely want plenty of contact to the patient. We can reapply to our patient every 1 to 2 hours. Good education to give to our patient. Application time is roughly 10 to 15 minutes for cold packs. 10 minutes is what I would use for our marker. We could use ice packs. So I know some clinics have an ice machine, especially if you do a lot with athletes. They have just an ice machine where they generate ice and put it in a plastic bag or in a towel. A little bit more aggressive than ice packs. We could make our own. So 4 parts water, 1 part rubbing alcohol. That's going to get really cold. That's a nice little science experiment. If you have any rubbing alcohol at home, you can play with that. All right, the next thing I want to talk about, then we'll start practicing ice massage. So ice massage, we're going to use a cup, a paper cup that's filled with water and then frozen. So that's creating a little ice cup. This is an intense cold application, usually really good for small areas, muscle bellied or a trigger point. Application time is until we reach that N of C-band, until we reach that numbness part. Usually occurs between 5 and 10 minutes with this form of intense cold. The burning and aching should only last about 2 minutes. So again, that's something good to educate our patient on. Okay, you've got this acute problem. I think this ice massage is going to be best for you. It's actually something you can do on yourself at home. That's another really nice thing. But it is uncomfortable, that burning and aching. The term to remember is C-band, cold, burning, aching, numb. We want to get to numb. The burning and aching should only last about 2 minutes. So if you can get through the discomfort for about 2 minutes, you're going to be happy at the end. That'll be good for you. Small areas like tendon, bursa, trigger point, small muscle belly, between 10 centimeter and 15 centimeter area is what we're going to be using it for. Not a big area. We're really a small area. So when we practice, I want to make sure you grab your tape measure. One, you want to know what the penetration depths that you're reaching are. That's always important to get that visual of what is the penetration depth and what is the tissues in front of me. But also now we want to look at, okay, the treatment area, 10 centimeter by 15 centimeter area. So it's not a large area. Okay. All right. So we've got a couple things we want to practice. One, let's practice our cold pack application. Make sure that everything's fine with that. The pillowcases, we're going to use that as our dry medium. And then we're going to use our ice massage. We have ice cups in that freezer there. The big thing is making sure we have toweling to catch all of the melting ice that's going to go around. So tucking in your towels into clothing to protect them is always good. And making sure that the toweling is underneath of them as well, because again, this stuff's going to kind of be a mess a little bit. Okay. Yep.
Is it just like you're applying the ice directly on?
Yep. Little paper Dixie cup full of water. We froze it. Now it's ice. Rip off the top portion of it. Keep some of the paper for you as the practitioner to hold on to because your hands are going to get cold. Sometimes I grab myself another little towel and I hold it with a towel. And then that's it. We're just going to apply it. Yeah. Yeah. Now, we have little like push pops. Like, is that what you? Yeah. Yep.
I never knew that.
Yep. That's it. So we could have minimal pressure, and yeah, I'm exchanging cold. Or I can add more pressure, and especially once we start learning massage, we'll look at direction of stroke and we'll see which directions are important. Maybe I would like cross friction. Maybe I want to go with the same direction of the fibers. But the more pressure I put on, I'm also doing what? I'm adding more what? Non-painful stimulus. Yeah. Yeah. So this is exactly what it would be. Yep. Okay. Well, the massage piece would be the non-painful side, and maybe that is what you want to do because the cold is burning and aching and uncomfortable. If I add more friction, more pressure, that is the non-painful now. So yeah. Close to it, yeah. Emotionally, yes, but physically. All right, so we're going to practice cold packs. We also have all of these in the freezer. We can practice this. Make sure I just made a mess here, so make sure that you have plenty of toweling to catch the mess, okay? All right, how do we feel with our ice massage? You surprised at how much it hurt initially? And you know, at first it's just cold, but then that burning and aching, it's like, wow, that can be intense. So that's definitely something we want to educate our patient on. How about once we got to numb? Yeah, great. Yeah. How much time did it take? Anybody take more than 5 minutes to reach numbness? Yeah. You thought it was a little bit more than 5 minutes for you? Yeah, right around 5. Yep. Yeah, good. What do you think benefits are of the ice massage over the cold pack? Quicker. Yeah, definitely. Yeah, the more focal the area that we need to cool down, the ice massage is perfect for that. Any others?
I'm getting that 2-in-1 where you're not only massaging, but you're getting the cold.
Yeah, if anybody try to focus on adding that non-painful stimulus, being a little bit more pressure with actually doing a massage portion of it. So yeah, I get to add our non-painful stimulus with that. Cold pack, we just put it on and say, feel better, you know? Yeah, but yeah, we get to do that.
A smaller area.
Yep. Yeah, a smaller target area, man. This is really good for that area. Yeah. Cold packs, advantage of cold pack. Larger area is probably the number one. Yep. Doesn't melt. Yep. So yeah, I mean the mess is a consideration, definitely. Yep. Anything else? The intensity is less, so the comfort is more. So again, if we're using cold as just as a non-painful stimulus, then yeah, I think we've got some concerns with the ice massage because it is uncomfortable. Although once we get to the numbness, boom, we finally got analgesia. That's great. But yeah, it can be uncomfortable during that time. So yeah, the pure non-painful stimulus. Yeah, larger area. What else?
I want to make sure for the ice massage it wasn't going any deeper though, like centimeters wise. Like no.
Yeah. Nope.
Okay.
Yep.
It just feels so in that one area. It feels like it's doing more. I don't know if that
Yep.
it's not. But.
Yeah, I think that's pure sensation. I don't think that the underlying tissue is actually getting any additional benefit.
It's 1 to 4 though, right?
1 to 4 for cold therapies, yes. Yep. The longer duration, the bigger the depth. Actually, I was on a flight flying out to a physical therapy conference, and I sat next to the flights to PT conferences are funny because they're all PTs on the flight. So I was sitting next to somebody, and she was giving a presentation on her research, and her research was all various modes of icing and what is the penetration depth we're actually getting to. And her research, her team would implant a thermometer underneath the skin, like into the muscle belly, and actually measure it directly that way. So who wants to volunteer for that study?
Let's go.
Yeah. You'd get a good handshake at the end. So I was talking with her about her research. It was fascinating. What she said was basically like, yeah, we're not doing anything here. So anyway, the physiology of the cold, I think it's important to think of. If my patient fits the indications of cold, I'm going to do it. But I'm not going to kid myself when there's precautions that I need to be careful of. If they have high blood pressure as their past medical history, I check their vitals and they're high today. Knowing that high blood pressure is a precaution for ice, because I'm skeptical on the physiology of it, I think I'm going to skip it today. The psychology of it, it feels nice when I have cold on it. When we do ice massage, I don't feel this, and therefore I don't feel pain. Yeah, that's nice. That's good. I don't think we're doing anything to the tissue, but it feels nice. So I think that's something to always balance in our heads. All right, let's move on. We can do cold water immersion or ice baths, either just cold water or with ice itself. immersion in water that contains partially melted ice cubes. Really good for distal extremities to, again, conform around the odd shapes of hands and feet. Also, we could use larger body area. We'll look at the different types of water tanks and stuff next. Water temperature should be between 55 and 64 degrees Fahrenheit. And again, we want to reach that numbness part of C-band. So the duration is until we reach that numbness part. Usually not treated for very long. Some patients not at all. It's can be really tough initially. So it's basically the same sensations that you guys just felt with your ice massage. That sensation, except you're submerging the body part. We'll talk more about using water as a modality next. No, it should. You said whole body.
Well, like if you're.
No, the duration should still be. We should reach that end part within 5 to 10 minutes, and the burning and aching should last about 2. That's the same, yeah. All right. Lastly, vasocoolant spray. Where's my sprays? Where do we put them? One here. All right. So these never see these clinically. Actually, I don't see these in the United States at all. Where I do see them is when I watch international wrestling tournaments, and it's all the former Soviet bloc countries that all use it. The Georgia, the country. Oh, in soccer, I don't. Yeah. Well, I don't. Like I said, where I see it, I would never see it in a soccer tournament because why would I do that to myself? So all it is, I would tell Kevin, yeah. All it is different types of alcohols. Each brand will have a slightly different type. So one of the things you have to look at is someone have an allergic reaction to that specific type of alcohol. I don't know of anybody that knows, oh no, it's this type of alcohol I got to stay away from. So again, skin checks all the time. We always have to do skin checks. If they have a negative reaction, we're not going to use it again next time. Good for trigger points. Again, most of the time we see this stuff is during the middle of sports competitions, because we can't just say, oh, you got your calf strain and playing soccer. Here's an ice pack. We'll wrap it on. All right, go. Good luck. Go score the goal. Right? We can't do that. Right? So it's just for immediate pain relief for that. So good for trigger points. That's the other thing for it. The textbook says make 2 to 5 sweeps with the spray in direction of the muscle fibers from origin to insertion, while also stretching the muscle. That's nice for the textbook to say. Fine. The instructions on this say a little bit different, so you can play around with it. And again, I think with your clinical expertise, if you're ever called upon to say, okay, go stand on the sidelines, here's your sprays in case anybody has an injury, then you get to use it. Not something we're going to spend a lot of time with in class. You can feel free to play around with it. But all it is, you just shake it, and all it, this says 12 to 18 inches away. The instructions on this say 3 to 7 inches away. So I would follow the can and not the textbook, because why would the textbook know anything about this, the design of this? But yeah, all it is you just, that would be, if you wanted the sweep store, or if you wanted, I see a lot of times it's just sprayed kind of directly on that point. And it does feel cold. That's definitely feels cold here. So feel free to play with it. Not great for the environment. So if anybody's really against, not against the environment, for the environment. I hate the environment. We could also use things called cryo cuffs. If you've seen post-surgical patients, you've probably seen some of these cooler with tubes in it, and it just circulates cold water through. It actually looks a lot like the compression stuff that we use. Remember that mechanical compression we looked at last semester? It's just a big compression sleeve around the limb, and then the cold water circulates through it. So that's all it is. The cooler, you swap out the ice whenever it works. You could have mechanical unit as well. But usually the ones I see are with ice chests. That's it. Anybody have one of these or use one of them?
Yeah.
Oh, yeah, yeah. Yeah, well, you know, the first thing we talked about, and I want to spend more time on it, we should have spent more time on it, is while I am skeptical on all of our modalities for are they doing something to the physiology, psychology, taking away pain, taking someone's pain from a 7 to a 4 is incredibly valuable. And I don't want to ever minimize that. And especially if we can take someone's pain from a 7 to a 4, if they don't have to reach for those medicines, narcotics, but even non-narcotics, what's the risk of non-narcotics? GI disturbances, yeah, ulcers being the main one that we have to worry about. So even if we relieve that from our patient where they don't have to use medications of any kind, then that's going to be really important, especially if it's the heavier opioid level stuff. So I think this stuff, you know, taking away someone's pain is so valuable. I think we overthink it when we talk about the physiology of, are we actually getting the target tissue? Do something to relieve their pain. That's great. That's wonderful to do. And I think these cryo cuffs are really cool. Pros of it, what do you think? Some compression along with it, with the cooling effect. Yep. Yep. Yeah. Use it for a long time. Yep. Yeah, we can get it home. It's not like the fluidotherapy where we say you got to come here for it. Yeah, we could get a unit for our patient for home use. What are downsides of it? Yeah, so there's a water and ice refill that we've got to do. So yeah, if I have really painful arm, how am I going to do carrying that ice and water? So there's some setup concerns with it. What else? What do you think? No, once you're on, I mean, you're sitting there for a while. Yeah. So, yep, completely locked in place. So yeah, there's some setup concerns with it. All right. Any questions on cooling? All right. So the next thing I want to do, we'll take a little break. The next thing we're going to do is we are going to talk about hydrotherapy next. So both cold water immersions, but also exercising within water. So that'll be the next thing we do. Okay. All right.